I've been asked to talk about the use of ultrasound, and I want to make you taste the full fruit and flavor what ultrasound can actually give to the pediatric neurosurgeon or neurosurgery in general. So we divide the talk in diagnostic and intraoperative ultrasound, and if we think of intraoperative ultrasound, the first thing everybody thinks of brain tumors, because that's where we use it most of the time. And if you think of brain tumors, everybody thinks of intraoperative resection control. That is, I think, where ultrasound is mostly familiar to most of us. But I want to show you that even for brain tumors, you can use it for much more. You can start with screening for raised intracranial pressure and hydrocephalus. I will show you how that works. You can use the ultrasound to guide your ventricular catheter for an intraoperative EVD. You can use it to guide endoscope placement for endoscopic surgery. You can even use the ultrasound for needle biopsy of larger tumor. Every tumor bigger than 2 centimeters, which is not in the brainstem, can be also used and biopsied by ultrasound. And you can use it postoperatively, again, for management of hydrocephalus and, for example, for research tools like pre- and postoperative CDF measurements. So you can also use it for Chiari decompression to check for the amount of decompression. You can use it for all kind of interspinal surgery and localization. And we often use it in peripheral nerve surgery for diagnostic and intraoperative purposes. Talking about diagnostics, what can we use ultrasound as a diagnostic tool? Because that's normally, we think, the job of pediatricians or neuroradiologists or pediatric radiologists, but you should be able to do most of these things by yourself, because then you don't have to rely on other people. You can use it for screening of raised intracranial pressure or monitoring the intracranial pressure over time. I'll show you how to use it. You can use it very nicely to screen for ventricular size or monitor the ventricular size of the children with hydrocephalus you are treating. We use it for screening and monitoring of pseudotumor cerebri and the effects, for example, of acetazolamide therapy in these children. I'm not going to talk about diagnostic ultrasound, for example, for spine pathology in the newborn. We use it for craniosynostosis. We almost do not do any CT scans anymore to prove an open or a closed suture. It can all be done by ultrasound. And I'm also not talking about peripheral nerve ultrasound, where we use it in nerve injury or in tumors, for example, in neurofibromatosis. So if we take the example of pediatric brain tumors, we need a screening tool, because the reality is they often cause raised ICP and hydrocephalus, but the obvious symptoms are very unspecific, and brain tumors are rare. So you would not initiate imaging for the first symptoms of vomiting and headache. Then you have the problem of accessibility to MRI. You have specific needs like cystation, so MRIs are often postponed. In consequence, many tumors are detected quite late, when the kid is already exhausted, has a big tumor and a large hydrocephalus. So what we would need is something where we can very easily screen and detect raised ICP and hydrocephalus. It should be non-invasive and radiation-free for children. It should be applicable without sedation also to smaller kids. And it should be, or should have, a very high negative predictive value. So if you exclude raised ICP and hydrocephalus, you need to be sure that this is true. Ultrasound can do all this, and I want to show you how you can use it for diagnostic purposes. If you think of an ICP, the first thing we do nowadays is an ONSD, which is optic nerve sheath diameter. This is the diagnostic window to the intracranial compartment, and you can see here that the subarachnoid space is very nicely connected alongside the optic nerve sheath. So if the intracranial pressure rises, CSF will be pushed alongside the optic nerve into the orbital cavity in there, because the dura can expand in the periorbital fat. The optic nerve sheath is going to dilate when you have raised intracranial pressure. And this is an online tool. This is a matter of seconds. So how you measure the ONSD, if we have the eye here in the anatomical cross-section, we take an ultrasound above the eye. It should be 10 megahertz linear with a mechanical index. You have to adjust this and lower this not to damage the eye bulb. And then this is what you get. In red, we see the optic nerve, which is surrounded by the optic nerve sheath. And then we have a picture like this. This is what we see in real time. In the middle is the dark black, is the optic nerve. Then we have the blue, the optic nerve sheath, and we always measure 3 millimeters behind the bulbous. The same thing, actually, if you know how to look for, you can see in MRIs, like this actual T2 weighted MRIs is very nicely. And the question is, does that actually, I have to just adjust something here, I'm sorry. This is disturbing my presentation, so we continue. Does that actually correlate well to the ultrasound? And we investigated this in 46 pairs of patients where we had MRI on the ONSD from the MRI and the ultrasound, and you see it's fairly similar. If you look at it, it correlates extremely well, or ultrasound and MRI, but correlation does not mean that you actually measure the same. So if you do a Blandon Ullmann plot, you see the bias is very low. It's 0.18. So MRI underestimates the true ONSD, and the gold standard actually is the ultrasound. It's not the MRI, by about 0.2 millimeters. So this is just something you have to keep in mind if you want to compare an old ultrasound ONSD with an actual ultrasound ONSD with an MRI ONSD. So the next step is, how does optic nerve sheath diameter actually correlate with invasively measured ICP? We investigated 72 children with all kinds of measurements for ICP. As you can see here, we investigated them awake and under general anesthesia or under sedation in all kinds of pathologies. And if the child is above 1 year of age, means it has a closed fontanelle and the sutures are more or less stiffened, you have a very, very good correlation in the whole cohort here of 72 patients with a correlation coefficient of 0.36. That means the higher the ONSD, the higher is going the ICP to be. If you look at the age, and if you look at children below 1 year, it becomes not that good anymore. The correlation is lost, and if it's an open fontanelle, there is no correlation. If it's closed fontanelle, a little bit better. But basically, under the age of 1 year, there is no good correlation, and you cannot use ONSD to assess ICP. Beyond that, it's a very, very good tool. Why is that a very, very good tool? Because you see here the cutoff, which we have calculated, the cutoff from a large set of patients to indicate an ICP above 10 millimeter of mercury is 5.3 millimeters. And it's an extremely good sensitivity and specificity. This is the perfect diagnostic test in this ROC curve. And the cutoff for 20 millimeter of mercury is roughly 5.8 millimeter. It's not as good in specificity, but still sensitivity is very good. So we have defined cutoff values, and now we have looked in 225 patients on the clinical relevance of ONSD with regard to ICP increase. And 104 children did not receive any therapy. They were just received the therapy and to decrease ICP, and their mean ONSD was 5.8. And in 122 patients, we, from clinical decision-making, said there is no intervention needed, and the ONSD was 4.8, so a clear difference. And if you look again at the cutoff value, it's again 5.3 millimeters. So 5.3 indicates an ICP bigger than 10 millimeter of mercury, and also indicates a high likelihood of clinical relevance of the symptoms the patient has. So this is the first take-home message, and ONSD above 5.3 is clinically relevant if you have a symptomatic patient. Now we move to the individual patient, because we were only looking at whole cohorts. If we look at the individual patient, we have 10 patients here. And if you look now on the individual curve, you see the individual has a linear relationship between ICP and ONSD. So in one individual, any change in ONSD is correlated one by one to change in ICP. And if you have two data points from one patient between ICP and ONSD, you can even take a formula and calculate the ICP from the ONSD. But you see, in every patient, it's a very different curve. So that tells you that each individual has a very linear correlation, and this makes ONSD so valuable if you follow the patients over time and want to assess a specific situation in the patient. All this has been the work of Susanne Kascher in the last years, which did this scientific workup of the data and has just been published in Child's Nervous System and is available to you. Now, we switch gears to ventricular size. I told you can also use ultrasound to determine the size of ventricles. If you think of ventricular size, you probably think of an MRI or a CT scan in those children. I want to show you that the first thing you should think of is ultrasound again. Transtemporal ultrasound measurement of the third ventricle. The neurologists have done this for many years for movement disorders and looking at the midbrain, and defined age-dependent normal values for children, which is 1.5 in a healthy child and about 3 to 4 millimeters in an adult. Now the question is, can we see the third ventricle by transtemporal ultrasound? And of course, the answer is yes, in 90% of the cases. So if you start from a transtemporal window on the mesencephalic level, you will see here black in the middle, these two olive things. This is the mesencephalon and the two cerebral peduncles. The yellow is the substantia nigra and the little asterisk is the aqueduct. And this is a axial scan. If you tilt then the ultrasound a little bit higher upwards, and in the middle scan we have the yellow arrow, this is the pineal gland. The two asterisks is the thalamus. In between these two little lines, these are the two walls of the third ventricles. And if you measure here across, you get a very precise measurement of the third ventricle. So in 90% of children, you will be able to assess the third ventricle by a transtemporal ultrasound. The exception is only children with epilepsy or overdrainage, which have very thick bones. The next question, if you want to use this, is does TVD actually correlate with the gold standard, which is now the MRI? And here we have three examples of TVD. In the lower ultrasound, you again see between the two little asterisks, you see the two walls of the third ventricle, and it looks quite well. We have investigated this scientifically. Susanne, again, with Luise Schweitzer, our medical student, and they looked at 122 pairs of MRIs and ultrasound TVD done at the same time when the MRI was done. And you see, again, an extremely good correlation between MRI and ultrasound. Correlation does not mean that you measure the same. If you do the Bland and Altman plot, you see very nice limits of agreement, and the bias is 0.2 millimeters, 0.12 millimeters. That means in ultrasound, the TVD is 0.1 millimeter larger than in the MRI, and this is very nicely explained by the fact that here on the left side, the MRI is an axial scan and the ultrasound is a slightly angulated scan, so you have a little bit higher passage or transverse through the third ventricle, and that explains why it is 0.1 millimeter larger in ultrasound. But that is not relevant, actually, as I will show you later on. So in 90% of your kids, if you can see the third ventricle, you can rely on ultrasound as you would rely on an MRI scan. Now, the biggest question, if we want to use ultrasound to determine the third ventricle, is the question whether changes in the third ventricular diameter actually reflect changes in the lateral ventricles. We are used to look at lateral ventricles. We normally don't look that much on the third ventricle. So we investigated 170 children and almost 400 MRI, CT scans, again, Louise and Susanne Kerscher's work, which has been published recently and is available to you. And what we looked, for example, is changes of the cellular media index and the front-occipital horn ratio after therapy of hydrocephalus. And you see nice correlation between the decrease in cellular media index and the decrease in third ventricular diameter in different types of pathologies, a very nice correlation of 0.7. And the same, for example, at the time of acute shunt failure. Here you see the correlation between the increase in cellular media index compared to the previous scans and the increase in TVD in percent. Very nice correlation. And now we do the same thing we did in ONSD. We look in the individual, and here we have 8 individuals with measurements between frontal occipital horn ratio and TVD at several time points. And again, we have an almost linear relationship in the single individual with a correlation index of 0.9 something. So in the individual, any change in TVD, you can be sure, has a one-to-one correlation to changes in the lateral ventricles. So in summary, changes in TVD signify changes in the lateral ventricle. You can be sure about this when you monitor this by ultrasound. That means you don't need a CT scan to know whether this child has a change in ventricular size if you can image the third ventricle and the third ventricular diameter. So we come back now to our initial question that we need something to screen for raised ICP in hydrocephalus, for example, for a child which comes in with question, does it have a brain tumor, yes or no? So in 5 minutes, you do 3 scans of the orbit and check if your ONSD is above 5.3. You do 3 determinations of TVD, and if the mean is above 2 millimeters, you know that this child with tumor-like symptoms has an increased ICP and has hydrocephalus after 10 minutes. And then you do your emergent MRI scan. If the child has a normal TVD and normal ONSD, it's not very likely that it has a brain tumor, but you will miss some. You will miss those tumors in the posterior fossa, which are very small, don't cause hydrocephalus and raised ICP, but irritate the brainstem locally. And you will miss supratentorial tumors that don't cause ICP increase or hydrocephalus. But it is a very good screening method in the first thing. And you will observe these children and get a scan later. How can you use these techniques after brain tumor treatment, for example? This is a child which had this pilocytic astrocytoma removed. We see the third ventricle. We see the TVD pre-operatively. And now post-operatively, you see how the TVD comes down post-operative from 15 point something to 9 point something, and then we wean him from the EVD. We gradually raise the EVD, and it comes to a new plateau, and he is, this way you can very easily monitor. You don't need a CT scan after clamping of the EVD to know whether the ventricles blow up or not. You do it by ultrasound, and this is the TVD at the time of discharge. Different example, another pilocytic after removal of the tumor, we raise the EVD, and after clamping the EVD, you see we get an immediate increase of the TVD. We do an ETV, and the TVD comes down in the following days, and this is the TVD at the time of discharge, which is remarkably smaller. You can compare with the scan immediately above. So for postoperative management, we don't need scans anymore. We just use the ultrasound to see whether we successfully wean the children. And the same happens, of course, with ONSD. At the time of high ventricular pressure, we will have an increase of ONSD. So if we want to manage children with hydrocephalus, not only tumor children, we do ONSD and TVD on every routine visit. And the child comes in for a routine visit once a year, and then we know what are the individual normal values for ONSD and TVD when the child is well. We adjust valves if we want to do that, and we can see are there any effects on ventricular size. You can detect silent over or under drainage. If the child comes in and suddenly the onus D goes up, you know something is wrong, or the ventricles dilate. Even if the child does not have symptoms, you have the first detection of shunt malfunction at a time when the child is still asymptomatic. If a child comes into the emergency room with vomiting and you think it's query shunt malfunction, if onus D and TVD are unchanged, we do not do a CT scan anymore. We observe the child for one night, and so far we had no false negative onus D TVDs in this series in the last years. If onus D and TVD are up, we know we have shunt malfunction. We still get a scan for medical legal reasons before we go to the OR. After shunt revision, you monitor the recovery of the patient, and the same is true after ETV or ETV revisions. You put in an ETV if the ventricles come down and the onus D comes down in the next days, you know that the ETV is working. And if you check after a few months and everything goes up again, you know you have ETV failure, even without doing a scan. So this combination in our hands replaces a lot of CT and MRI scans for follow-up and in the acute situation when a child comes to the emergency room. So currently, this is our number one tool in hydrocephalus and also pseudotumor cerebri management, and we wouldn't know how we did it before, because it really has changed our practice a lot. Just two examples. If we only see the indicator for relevant ICP increase is 80 patients, and you see with acute hydrocephalus, you have a high onus D and you have a large ventricle. In pseudotumor cerebri, you have a high onus D and small ventricles. So very easy to distinguish just by ultrasound raised ICP from pseudotumor cerebri. And this is a case example. Maddox is a 6-year-old boy, fatigue, nocturnal enuresis, and pain of the eyes. So very unspecific things. We do an onus D, we see it's high, 6.4, 5.3 is the reference value, and we see small ventricles. So we suspect ICP increase without hydrocephalus and recommend further diagnostics. The ophthalmologist tells us no papilledema, everything fine. The boy has no raised ICP. We do a flapper MRI because we think he has pseudotumor cerebri, and indeed we see that the left or the right transverse sinus is missing and the left transverse sinus is not contrasting very much. We do an LP with an opening pressure of 38 centimeters of water, and immediately after withdrawal of CSF, he is free of symptoms, and the onus D comes down immediately. So this is a minute-by-minute thing. You can, after LP, the onus D came down from 6.4 to 5.2. And then we started him off acetazolamide, and we leveled the onus D at about 5.5 under treatment, so we knew he's fine. And when we tried to wean him a year later, the onus D was coming up above 6, and the symptoms recurred, and eventually he ended up with an LP shunt. So very nice example to show you how these parameters can aid you in managing patients. Okay. Now we stop with the diagnostic applications of ultrasound and move on to intraoperative ultrasound. As we all know, surgery depends on vision and visualization. We are visual animals, and what we don't see doesn't exist for a surgeon. Basically, that is true. So we need a morphological correlate, we need a target, and we need pre and obvious also sometimes intraoperative visualization, because we benefit from intraoperative visualization very much. Intraoperative, the surgeon truly depends on what he sees with his eyes through the microscope, and which is beyond the reach of his eye. He uses some kind of visualizers. In the surgical field, it's the ultrasound, which is real time, or it's in neuronavigation. But we know neuronavigation is historical data. It's the data before we started surgery, and brain shift and everything else makes the navigation less and less useful the longer surgery is carrying on. We can also use extra field surgical eyes like fluoroscopy or intraoperative CT or intraoperative MRI. And if we look now at cost, time, and practicability. And the more red, the more cost, the more time, and the less practical. Intraoperative ultrasound is the number one in each category. It's the cheapest, it is the fastest, and is the most practical. And intraoperative MRI, which is a great tool, which we use a lot and which we love a lot, is expensive. It takes you 1.5 hours to get the scan, and therefore the practicability is much lower, although the resolution, of course, is unbeatable for certain pathologies like low-grade gliomas. So the ultrasound is the surgeon's third eye to see beyond. And as you all know from A Song of Fire of Ice, the three-eyed crow is the master of everything. So we need a third eye to see beyond in surgery. And in any kind of surgery you can use the ultrasound. The role of ultrasound in surgery is orientation. To check, is my craniotomy or my laminectomy in a spine surgery, is it correct? You look at the preoperative sono characteristics of the tumor. You localize landmarks. Where are the vessels? Where's the ventricles? Where's the cyst? Where's the relation of the tumor, for example, to a certain vessel which runs through the tumor? You navigate to targets. You can use it to navigate the surgical approach. You can do a biopsy or a puncture of the ventricles or whatsoever. You do a biopsy under visual control as an alternative to frameless biopsy. You place ventricular catheters, you navigate, you resection control. Finally, the resection control. Which probes do you use? If you have a craniotomy, you can use these small curved or linear transducers, which you can even bring into the resection cavity. And for burr hole, you have special probes. And burr hole ultrasound is the most useful tool, as I'll show you in the next slides, because you can do a lot through a burr hole. You can do an orientation if your burr hole is correct. Are you on the sinus or next to the sinus, for example? Are they at the edge of the tumor? You just check through the burr hole before you do your craniotomy. You place ventricular catheters and endoscopes. I'll show you examples. You puncture an abscess or an hematoma, you biopsy a hemispheric lesion which is large enough, and therefore it is a true alternative to frameless navigation, which is much cheaper to buy and more versatile. There's no extra imaging you need for registration, and we know an MRI in a kit means maybe sedation if you don't have a navigational MRI. You don't need head fixation, you have minimal cost per use, you have minimal extra time, and it's always live. So it's a truly viable alternative to frameless navigation in many instances. For example, ultrasound-guided placement. You have a burr hole ultrasound, you check the ventricles, you remove the burr hole, you do a parallel movement of the needle, and then you puncture the ventricle. You remove it and put in your catheter, and this looks intraoperative. It looks like that. Oh, sorry. I have to run it through again. So intraoperatively, it looks like this. We have the burr hole ultrasound. We have the brain needle. We do our scan to determine the perfect trajectory. Then I do parallel movement and slowly introduce in the exact correct trajectory the ventricle, and you see the dripping of the CSF. There's not much pressure on it, but we have a nice ventricular tap. If we have very small ventricles, we make a little bit bigger burr hole so that we can puncture the ventricle under permanent visual control, as we see here. And then again, we can insert the catheter, and I'll show you an example how we puncture the ventricles in a 9-month-old baby with a recurrent suprasellar arachnoid cyst with optic nerve compression, and we do an ultrasound-guided puncture with the endoscope for fenestration. You see not very big ventricles, 9-month-old child. Otherwise, you would need to use frameless navigation to hit these ventricles. So we do an oval-shaped burr hole. We have the trocar of the pediatric endoscope next to the ultrasound. And this is what you see. We see the ventricles in the middle. We see the cyst below at 6 o'clock. you see the hyperreflexive choroid plexus. We do a scan backwards and forwards, orient ourselves at the choroid plexus, which is hyperreflexive. Now we have a very nice picture, the cyst, the lateral ventricles. And now you see how I do a live navigation of my endoscope trocar inside the right frontal ventricle. And you can nicely see here on the left, you see the movement of my hands. And now you see even the plop. You see plop. Now you're inside the ventricle. And here we are with our endoscope right on top of the arachnoid cyst. Similar situation, catheter placement, intraoperative guidance. We have this isolated posterior third ventricular cyst in the third ventricle and aqueductal occlusion. So we want to do a stent catheter inside the ventricle and inside the cyst, which you normally would use, again, frameless navigation. And here we just do it by ultrasound. We have here the ultrasound. We have the cyst. We don't see the endoscope. It's a 5-month-old baby. This ultrasound is on the fontanelle. And now you see the laser fiber, which is here on top of the cyst. And when we see the bubbles inside the cyst here, we know that we actually have successfully under endoscopic view. At the same time, I have the endoscopic view and see that what I'm doing. And in the ultrasound, you see that I have now opened the cyst, and then the catheter is introduced under endoscopic view, and then connected to the shunt. And in the end, you check again whether your ventricle is actually, your catheter is in the correct position, as I show you here. And we very nicely see the tip of the ventricular catheter in the third. In the cyst in the posterior third ventricle, and here's the lateral ventricle, and we can check, and you don't need a postoperative CT scan or anything to be sure that your catheter is in the correct position. Finally, I show you an example, just what we have seen before. In open fontanelle, you tilt your ultrasound, and then under direct vision, you puncture your ventricle. And we have the video coming here with a child with a post-hemorrhagic hydrocephalus. We see the parenchymal defect on one side, and here comes now the ventricular catheter under direct visual guidance inside the ventricle. And we see the puncture, and we have a very precise position. Talking about position, the question is, does position actually matter, and how precise are we with this ultrasound-guided placement? We investigated this in 128 first-time shunt insertions, 90 patients. We had enough follow-up. First-time shunts, mean age 4 years, and we hit 89 of 89 ventricles in the first attempt, mostly frontal catheters. The position of the catheter was in 65% ideal, in the middle of the ventricle, not close to any wall. And only in 3% we were not in the ventricle, which we actually intended. We were too deep down in the foramen magnum or the foramen monoid third ventricle or contralaterally. So 89% of the catheters were in the intended ventricle, 65 in best position. And when we look at the occlusions, we had only a few early and late occlusions. And if you look at the catheter position, you see that 4 of the 6 catheters which failed were touching the wall, and 2 were in the middle. So 3.8% of the catheters failed which were in best position, and 12.9% of the catheters failed which were in non-ideal position. So positioning of the catheter seems to matter, and others have shown this in some other studies. There are studies, of course, which did not show an influence of the catheter position. In our hands, the occipital catheters fail more often than the frontal catheters, so we have stopped doing occipital catheters in children. Ultrasound-guided biopsy. This is a very easy setup. You put your ultrasound needle we have a holder where you can fix the ultrasound probe to your LILA system, and then you have the needle inside. You go to your target, and then under direct view with the ultrasound probe fixed in the LILA holder, you go with the needle next to these vessels. You see we push away a little bit the vessel until we are on the target, and then under visual control you do your biopsy, and you can also check immediately if you get a bleeding or anything like that. So ultrasound is possible and a very cheap way of doing brain biopsies if you don't want to use frameless navigation or stereotaxy. Finally, I show you a few examples of ultrasound-guided resections of brain tumors. This is an example of how we use it to guide the approach to the tumor. This is a 3-year-old boy with a H3K27M negative thalamic GBM. And we see it here in the left posterior thalamus, large tumor, almost intact child, very, very mild hemiparesis, nothing else. And this is the sagittal scan. And in these children, we use this posterior parietal approach, 3 centimeters off the midline and in the post-central region. And we used to push under ultrasound guidance a balloon in the ventricle, then slowly dilate the brain, and then in the channel we have created this way, we put in a plexiglass tube as a round retractor, and through this we perform the surgery. So what you see here is now the ultrasound-guided puncture of the ventricle just on top of the tumor. The tumor is down here. You see the tumor down here. Here's the ultrasound-guided thing. And now you see how under ultrasound guidance we start filling the balloon to slowly distend the brain, softly push the brain apart, not to suck your channel down and destroy the brain. And here again, we have now finally dilated a nice channel inside the brain. And in this, we can just now push down very gently the plexiglass tube, and then we are on top of the tumor right away. Very straightforward, guided approach to the tumor. You cannot use this ultrasound for these deep-seated lesions very well for resection control. So we did intraoperative MRI, which shows that most of the tumor is out. We still have a little bit of tumor here, and this is then the postoperative CT scan with a gross total resection in a child which had no other problems except a little acceleration of its hemiparesis, which went away in a few days. Now, ultrasound-assisted tumor resection, 6-year-old girl with a progressive pilocytic astrocytoma, which was operated at age 3, and it has been growing. And we have this large tumor in the tentorial incisura, partially infratentorial. There's an infratentorial cyst down left, down right image, and we have the tumor extending up. You can see this best, I think, here in the coronal scan with the tumor in the tentorial incision with a high-grade brainstem compression. What you see is that the PCA is inside the tumor, the posterior cerebral artery, and down we also have the superior cerebellar artery, and we decide to use the old approach, do a transtentorial approach to reach the intratentorial compartment and to dissect the tumor off. And I show you now the stepwise ultrasound. This is the ultrasound prior to surgery. We see the tentorium here, we see the vessels, we briefly saw the PCA here, and here we see the posterior cerebral artery, which is inside the tumor alongside the tentorium. These are the different cysts of the tumor. This is after some kind of resection. We see the pulsating posterior cerebral artery inside the tumor. Down here, we see the superior cerebellar artery. We have already reached the tentorium here, and we'll now open the tentorium. This is now after opening of the tentorium. We have this posterior cerebral artery here. We have the trochlear nerve here in the opened tentorium. And now we proceed with the surgery. We still have to take this off the brainstem. And this is at the end of resection. We see the posterior cerebral artery. Down here is the posterior cerebral artery with its branches. The tumor is now removed. You see the superior cerebellar artery down here, and this is the brainstem. This corresponds to this part of the brainstem, and this was the end of resection with a nice postoperative result. Very little residual tumor down here, and a little bit residual tumor alongside the posterior cerebral artery here. This picture now shows you something which is very important. If you look at this scan, you will say, damn, here we think there is still residual tumor. Why didn't he take this out? Fortunately, we didn't do it because it's the brainstem. This is here. But why is the brainstem so bright and it looks like that there's residual tumor? This is a very known artifact in ultrasound-guided surgery, but you need to know this to interpret the images correctly. This is our post-operative end of resection scan, and the ultrasound waves are attenuated in the tissue on the left and the right in these two red arrows, and because it attenuates the beam, and inside the water in the middle, in the resection cavity, the beam travels much faster, and because it travels faster, it hits the end of the resection cavity, it hits the brain tissue with a higher speed, and therefore we have an enhancement, a signal intensity, and it looks like residual tumor. So the mecca of intraoperative ultrasound is in Trondheim, in Oslo, in the group of Geimund Unskar, with the god of intraoperative ultrasound, and they know, of course, of this problem, and they have started to develop an acoustic coupling fluid which actually has the same sonographic behavior like normal brain. That means inside the fluid, the sound travels at the same speed like inside the brain. And then you get rid of the artifacts, and you can see this very nicely here. On the left side is a normal picture with normal saline. You see the attenuation of the image with the hyperechogeneity, and on the right side the cavity is filled with the acoustic coupling fluid, and now you can clearly see that there where the orange spot is, this is where there is truly residual tumor. And this is an example. On the left side you would think that there is residual tumor, and when you fill the cavity with this acoustic coupling fluid, you see that there is no residual tumor at all, that you have a complete resection. So these images are taken from the publication with the permission of the authors. I talked to Tormod, and we think that this acoustic coupling fluid will be available on the market in about 1 to 2 years, and this will make a huge difference in intraoperative ultrasound imaging. Another example on the right side now is the Ringer image, and on the left side we have acoustic coupling fluid, and we can now clearly see the residual tumor, which was not so clear before. The last case I wanted to show you is how you can use this in spinal cord tumor resection. This is a 15-month-old boy with torticollis, which is his only symptoms, no other symptoms than that. And we see this very, very nasty pilocytic astrocytoma, which is diffusely infiltrating the whole spinal cord. This has no clear-cut borders except in the very top, in the very beginning. And you can see also on these scans here that it is a diffuse infiltration of the surface of the spinal cord. And that was exactly the intraoperative situation, that this was a diffuse infiltrating tumor. And you can also see in the higher resolution ultrasound, this is at 14 megahertz, our intraoperative linear scanner, and you see no clear border whatsoever between the tumor and the surrounding spinal cord. And here again, there's not even a hint where the tumor ends and the normal infiltrated spinal cord tissue would start, because it was indeed infiltrated. You see now the upper part, and you can nicely mark when you start opening the spinal cord between the dorsal columns, you put in a little piece of gel foam or Cerci cell, and you can nicely mark your dissection borders. This is the upper border, and this is the lower border of your opening in the spinal cord, so you make sure you are in the right spot in a situation like there where the tumor and the brain, the spinal cord tissue look very much the same. And then actually we did in this case a totally ultrasound guided resection because there were no borders. We just went in there and these potential IOM were more or less stable and more or less reliable in this child, and then we just work our way down according to ultrasound criteria and said, okay, this is probably the border. You could not actually distinguish it by eye. And then you work your way down in the spinal cord. And always remember that we have an attenuation in the middle. So the hyperintensity on the bottom is a wrong hyperintensity. This is not necessarily tumors. So we worked our way on ultrasound criteria, did a nice debulking. This is the postoperative scan on the right side. Almost all the contrast-enhancing tumor was removed, and we still had some edema, and we were quite happy with this result. And here you can see the infiltration of the dorsal columns and part of the spinal cord by the tumor. So in summary, we have a very broad application field for diagnostic and intraoperative ultrasound, which I hope I could show you in the last hour. Actually, from a diagnostic point of view, the ultrasound is the best friend of the pediatric and also the adult neurosurgeon. I think especially for the pediatric neurosurgeon because of the high load of hydrocephalus cases. And it helps us solve most of the problems in daily business with ICP and ventricular size. It's a great research tool. We work on global CBF, on local CBF. We have not talked about contrast-enhanced ultrasound and many other options which ultrasound might offer us, elastography, things which will enhance the possibilities of ultrasound in the future. It is a research tool. We are working to assess intracranial compliance with ultrasound. It is a great monitoring tool for everything connected to hydrocephalus. I showed you that you can navigate everything you want to stick in somebody's brain. Always use the ultrasound to know where you are and to see real time what actually is happening when you push things in other people's brains. It's an intraoperative tool for resection control, and with elastography and contrast-enhanced ultrasound, we might even put things further. And then there is the new integration of ultrasound into neuronavigation systems like BrainLab or other companies, where we will have a 3D ultrasound incorporated in the preoperative images. And this works already quite nice. And I haven't talked about intraoperative vascular imaging. You can look for the vascularity of tumors. You can look in AVMs. Where are your fetus coming? You can check aneurysms and very nicely also in the vascular cases. So in summary, please use ultrasound whenever you can. Thank you very much.